to move ahead to our presenters. They're going to talk about interprofessional communication for optimal education and practice. These are our Texas A&M Health faculty presenters, Dr. Juan Castro from the College of Pharmacy and Dr. Alison Pittman from our School of Nursing. So I want to welcome them, and I'm going to turn it over to them for their presentation. Dr. Castro?
Thank you, Chris. Thank you. Thank to everybody who's joining us this afternoon. I'm happy to be here, and basically because we're talking about the importance of interprofessional communication in providing optimal healthcare, especially because my background is for the last 10 years teaching at the College of Pharmacy, where I'm the only physician. There's a PA and the rest are pharmacists. So it has been an interesting experience for me. What we want to cover today is to be familiar with the definition for interprofessional communication, but also the importance of it. Why is we make such a 45-minute presentation? Why do we talk about it? Why do we bring it up to that? So we're going to talk about that importance, or what barriers are they keeping us from communicating effectively? And finally, also, what are some strategies that we can bring to the table that can help prepare our students better to communicate better with our other healthcare professionals? So we have a problem, but what problem do we have? Do we have a problem? What problem? So Bernard Shaw, I like this phrase, I'll read to you. He said, the single biggest problem in communications is the illusion that it has taken place. If you just think about it for a little bit, that makes you wonder, that has to take you somewhat back, because a lot of the times we think we're communicating good, we think we're doing our job, but maybe it's an illusion. And I'll go back to that. I'll give an example or two on that. But it's something to think about. Are we really communicating effectively? And so let's talk about what is interprofessional communication. We have talked in the last 15 years across all disciplines about interprofessional education, about bringing that up to the forefront of our training, interprofessional education. But interprofessional communication in itself, to me, that's the glue, the key of everything else we do. Because if we don't communicate well, anything else we're doing for education, for the training, is not gonna stick as good as we will want to. Now, IP communication is multifaceted. You cannot just grab it easily. It has a lot of factors, it has a lot of hands, and some of those I want to go over. First of all, it starts with oneself. We're not gonna train a student without advising them in a didactic way of what should our approach be. For instance, just starting with the body language, the way we stand, the way we move our arms. What message are we transmitting? Do we seem interested? Do we seem like we want to listen to that person? Are we standing in a way that maybe the other person feel like they are wasting our time? And I've seen that, and I've been there in those groups where you feel, this professional paying attention to me. I feel like I came from something more important. So what are we saying with our body? Are we in a hurry? Are we saying, I'm in a hurry, I gotta go somewhere else? So the body language is very, very important. How do you teach a student to do that? That's more in a didactic setting. What about the attitude? Are you, me, somebody, are you acting like maybe you're a superior profession? Are you acting like you'd rather be somewhere else? Are we acting in any other way that's going to interfere with our communication? Because once we give a bad sign to the other person, we might be already be shutting down some information or the way they communicate. Okay, so we got to watch also for our attitude. What about the tone? It is not only what we say, but it's how we say it. Are we talking in a demeaning tone? Are we talking maybe are we keeping a professional demeanor? Are we being bossy, not thankful? What's our tone? How do we address other professionals? So that's from the beginning, when we make our first impression, we're already communicating something even if we don't know it. So we have to be perceptive about that, on how are we approaching our team members before we even give that history or the presentation of our patients. Now, this type of communication, the literature explains it's two ways, synchronous and asynchronous. Synchronous communication basically is real time. It's happening right now, like I'm talking to you, we're listening to you. It's happening right now. So that's asynchronous. It happens at the moment, real time. And actually nowadays, it's not only face-to-face, but it's screen to screen. It's happening right now. It can involve meetings, any type of meetings involving patient care. How about patient rounds? Tremendous information there. It's an excellent way that we need to communicate clearly. It can also happen when we're changing shifts, when we're handing patients handoffs, signing off patients to somebody else. All of that is synchronous, very important communication that needs to be clear, needs to be delivered that way we want to deliver. That way we want it, because sometimes we want it one way, but what we say in our actions, the other professional might accept it in a different way. We'll give an example of that as we move on. And finally, another facet of the IP communication is asynchronous. And basically this is, it does not happen in real time. And this involves all written information. And nowadays, actually not only written, I call it keyboarded now, because we type it. We send it in email, we send it in prescription, etc. So anything that's in writing. Medication orders, a big one. Nowadays, with computers, with EMR, probably less errors than we had before, because we don't have to worry about being legible or not legible. And progress notes, whether they're handwritten or whether they're EMR, and also nowadays, whiteboard. So all of those will be synchronous. So how are we communicating? We're probably communicating all these four ways that we talk about: synchronous, asynchronous, our body language. So in doing this is, why do we care? Why do we go through this? Why are we trying to educate our students in all these areas to have a clear and effective communication? Well, patients can die. Patients get injured when there's poor communication, because we're delaying treatment in some cases, or we're misdiagnosing. And if we misdiagnose, patient is gonna get a different treatment. They're not gonna get what they need. And unfortunately, there's also, with pure communications, medication errors. And as you know, since 1999, when To Err is Human was published by the Institute of Medicine, this has come to the forefront more and more on how we can avoid that. And one of the main things was, we need better communication. So people can get hurt, patients can get hurt if we communicate effectively. What else? Well, there's, in another front, what can poor communication do? It can overuse, it can have our resources. We can inefficiently start using whatever the hospital provides, resources, etc. Essentially, it can have a negative impact on our economy, because we're wasting resources, sometimes duplication of tests. If I go to an MRI, the other clinician was not clear that had been already done. That happens, it happens around. And also, of course, this leads to higher healthcare costs, or performing procedures that maybe were not the best at the moment. And other outcomes that I have seen myself working in different clinics, and I'm sure most of you, a lot of you have seen other outcomes, is patients are not happy. They complain about our healthcare systems. They see there are the result, or they get the results of poor communication among us. On our end, there's poor job satisfaction. Professionals might not be as happy at work as they could be, because where there's poor communication, they're not gonna feel value. Their expertise is not, they're gonna feel like it's not being taken seriously or appreciated. And finally, we do see a high turnover rate in teams, in departments where there's poor communication. The literature shows that professionals start changing jobs. Even if they like what they were doing, they might go to a different hospital, different clinic, they change jobs. Or they retire if they're in that age where they can do that. Or they can change professions or give up their professions, which we don't want that, especially nowadays where we're short of healthcare professionals. So with that in mind, that's why we care, and that's the outcome of not communicating clearly. Let's talk a little bit about communication barriers. Okay, what is keeping us from communicating? But before we go in there, let me go ahead and have Dr. Pittman talk about competencies of.
Thank you, Dr. Castro. I'm Alison Pittman. I'm a clinical assistant professor at the College of Nursing, and I'm going to talk a little bit about some models and some best practices out there for interprofessional communication. When we look at the model that was put forth by the Interprofessional Education Collaborative, which you'll hear us call IPEC, one of the four competencies that they really push for is interprofessional communication, and we want that to be in a way that everyone who is at the table is equal. In other words, an equal team approach, and also a communication method that is responsible and is responsive to each member of the team. Looking at some of the sub-competencies, next slide please, that are involved here are obviously effective communication tools. There are a lot out there. Many of you are probably familiar with Team Steps, which is a great model that's put out that has some effective communication tools in the patient care setting. We also want to avoid using jargon and discipline-specific terminology so that everyone, including patients and families, can understand what is being communicated. Confidence, clarity, and respect are essential, as I'm sure you understand. And then principles of active listening, where we really are providing both verbal and nonverbal communication that really ensures that we are listening and valuing the ideas and opinions of everyone on the team. The rest of the sub-competencies really have to deal with giving timely and instructive feedback on performance. That feedback loop is very important, and we practice that with our students in our interprofessional settings. Obviously using respectful language, and my team that deals with LGBTQ curriculum is really paying a lot of attention to that because of some discrimination in language that our population deals with. How our uniqueness, each person who is sitting at the table of the team provides a very unique role, and that needs to be recognized and acknowledged from the beginning, and how they contribute to the team. And then lastly, of course, always focusing on the team and not the individual in terms of what it can provide in terms of patient-centered care. I think, okay, next is communication barriers. Dr. Castro is going to talk about those, and then we're going to go into our case studies.
Yes, let's talk about what keeps us or what makes it more difficult to have a effective, clear communication. And healthcare, as you know, all of you know, it's just has become so complex. It has grown tremendously, so rapid. The knowledge that we're getting every day, it's impossible to keep up with it. And thus, there's not a single person that can handle all the new material that comes in. So that's when teams become more important, and we depend on each other more and more. Some examples is we not only have cardiologists now, but we have the specialty, but we have subspecialties and subspecialties, such as we have a single physician now just doing, for instance, electrophysiology of the heart. I mean, that's such specialization, such as we have not only a specialist of the eye, but somebody who specializes only on a portion of the eye, like the retina, for instance. So we have become such a subspecialized in the last 20 years. In hospitals also, we have minor surgery hospitals. We have patients that when we discharge, now where do they go? They go to a nursing home. Do they go to skilled nursing unit? Do they go to a rehab hospital? It has made it much more complex for a single individual to keep up with that. And that's when we need a team. We need the expertise of everybody else so we can dispose of the patient or give treatment to the patient more appropriately. Now, once you are within a setting, a healthcare setting, such as a hospital, they're huge. They're huge institutions now. Sometimes, even here, we have 2 large hospitals in Corpus, nothing compared to the bigger cities, but still, even for us, it seems like you're in a maze. There are employees that know how to handle the hospital well within their area. But if you ask them about the other end, they're not too sure. It's such a big institution. Positively good care, but on the other hand, is the ability is team members might get a little bit intimidated. I don't know too much that. I don't want to voice my opinion, and we miss there. So that can be distracting. There's a high pressure environment. Things are getting done fast. And many specialists seeing the same patients, not a family doctor anymore who's there. Now we have the hospitalists who take care of the patient for that week, for the month. Many specialists come in, makes it more difficult to have a clear communication when the patient comes to me and I want to know what happened in the hospital. It is intimidating. It is intimidating. And we tend to ask less questions when we get intimidated. What about the lack of confidence and experience? Well, we know that as our graduates go to the workforce, they might not feel as confident in being part of the team and providing knowledge, but they do have the knowledge. They have a lot of new knowledge that they learn compared to the ones that we graduated years later, but perhaps they don't have the confidence. So as a team member, we gotta be aware of that. We gotta not only prepare our students when that happens, but we got to prepare other physicians, other nurses, pharmacists, older, that to incorporate everybody. And not only that, when a new hiree, even if they're not new graduates, but a new hiree gets to a new hospital, they tend also not to contribute at the beginning. And some information, some of the knowledge might be needed. Sometimes what keeps information from happening is the senior team members might look down upon the new people, the new members, etc. And definitely the lack of experience when healthcare professionals go from one department to another one, from one hospital to another one, they might not feel up to being there completely the first couple of months. And therefore, they might just go by without contributing to the team. So all of this, somebody has to take over the dynamics of the team and be aware that these things might be happening and encourage all those members to feel comfortable and provide, to communicate that it's okay. Give us your opinion, we need, and we want to hear what you have to say. What about the education? Well, the standardization, there's no standardization in how we teach interprofessional education, how we teach communication. There's a lack of structure. Medical schools do it one way, nursing schools a different way, pharmacists in a different way. There was an article in the literature that states the way nurses are educated, they tend to be more descriptive. They talk more about the patient. They want to give more of that social aspect, more of the holistic view of the patient when they make presentations, especially to physicians. In medicine, we're trained to be more to the point, more succinct, more, tell me the highlights. I want to make the diagnosis. So in this study, nurses, physicians, medical students, actually the study was with medical students. Medical students tend to say that the nurses take too long to make their point, that they're giving facts that are not needed for them to hear. While nurses were saying, hey, you know, physicians tend to be more inattentive. I feel like they're not listening to me. I feel like they don't want to hear my story, what I have to say, like I'm not valued. So there's a lot of things from each discipline because of the way that we're trained. Perhaps in the future, the thing will be is we can develop a protocol where we are educated similarly in communication. Everybody has their own discipline, but at least in communication, we have similar protocols, some basics. Also, your personal values, what you might bring as an individual, and then the other ones, you might have different goals. Your goals in your profession might be different than the team goals, so we have to be careful with that. Personality differences, some people are reserved, others are outspoken, some are introverted, others are extroverted. So in the team, there has to be somebody who asks the introverted, reserved person, what about your opinion? Not only the one that speaks the most, but the dynamics of the team. So personality differences can keeps somebody from providing to the group. What about hierarchy? Hierarchy is very important as well, because sometimes one professional might feel that's over another one, or that has more power. All hierarchies in all times, physicians were the leader of the groups. Not anymore. Doesn't have to be that way anymore. One profession might feel important than the other, so we have to be ready to change some of those beliefs. And finally, cultural background, generational differences. Culture, it's a given that we can have the culture can affect the way we act in groups. Generational differences. Graduated in 1991. What I consider appropriate behavior for a recent graduate might not be. What I consider respect or respectful for me, younger graduates, that might not be the case. And we're in the same team, so that might contribute to some miscommunication. What I consider good manners, new generations might not. And there's plenty of examples like that. As a teacher, what I do, what our students do, there's no way we're there to do when we were students back 30, 40 years ago. Finally, I don't want to talk too much about disruptive behavior. Actually, I don't want to talk about it mainly because when we're at this level as professionals, that shouldn't even exist. We are professionals. That should not even be part, but it is, unfortunately. And hopefully someday we don't have to add it as a way to affect negatively our communication. Let me stop there for now, and we'll come back with some strategies. Dr. Pittman.
We wanted to, thank you, Dr. Castro. We wanted to provide some examples, a bit of a case study for you. And I was asked to share my experience with our team that put together a interprofessional, a team of faculty and students to create a curriculum within the Texas A&M Health Science Center for LGBTQ health. And just to give you an idea, this all came about because I, as a pediatric nurse, working with youth and seeing what our students were learning and going to conferences, realized that there is a pretty big disparity in terms of our ability to educate health providers across the health science centers, all disciplines, on some of the problems and health disparities that LGBTQ folks have. And so I wanted to sort of close that gap, at least for students in our institution here at Texas A&M. So the way that we put our team together is I reached out, I had a passion for this, and I reached out to each of our colleges have offices of diversity and inclusion, and I reached out to the leaders in each of those offices within nursing, dentistry, pharmacy, medicine, and public health, and said, is there anyone on your team, faculty, staff, that are interested in looking at our curriculum specific to this at-risk population? And each of them recommended people that reached out to them and said, this is something I'm passionate about and I really want to help. And then in addition to that, we actually had a piece that went out in a newsletter called Texas A&M Today. And without me even thinking about it or realizing how important this was, we had students from the College of Education and the College of Medicine who reached out to me after seeing the piece in the newsletter saying, I am really passionate about this and I would really love to help. So we ended up with faculty, staff, and students across all of these institutions, adding on the College of Education over on the main campus, which is separate from the Health Science Center, which made it even more interprofessional and very special. And this screenshot that you see is just some of us. We said we were Zooming before Zooming was cool. We started meeting by Zoom because we have campuses in Dallas, in McAllen, down in South Texas, and in Houston, and we have members on all those campuses. So we've been Zooming together. We looked at the literature. We saw the gaps in each of our individual disciplines and our colleges. And we're putting together a survey that's in IRB right now where we're surveying our faculty and our students on what they feel like the gaps are in providing care and education to this target population. The reason I bring it forward is because I feel like this is an example of effective interprofessional communication, and I really chalk it up to the fact that everyone who's involved on this team is passionate about what we're doing. They weren't voluntold to do it. They weren't there under duress. And I think that makes a huge difference when you have a team of people that really care about the work that they're doing. And I know not every team can be that way, but if you can set the tone of what you're doing as being something that everyone has a vested interest and can be passionate about, we really, in the 1 hour every 2 weeks that we get together, we get some great work done, and we're really looking forward to where the team's going to go in the future. So that's just an example of a case study where interprofessional education and teamwork can be effective.
Well, thank you, Drs. Castro and Pittman, for setting the stage for us in terms of today's topic of interprofessional communication. We want to shift now to an open discussion about interprofessional education, and we invite those on Zoom to join in, ask questions, offer comments, because we want to hear from you about strategies that you may use to enhance interprofessional education or barriers that you've come up against. And I think maybe we could even start there. What barriers has the group on the call today encountered when it comes to interprofessional education? Interprofessional communication. Nobody's had any barriers for communication? The other option is to address some of the strategies that you've used to overcome barriers. What have you found as best practices for interprofessional communication?
Well, this is Dr. Ontai over at Victoria. You know, at our hospital, we have a, am I getting an echo with you guys?
You sound just fine.
Okay, good. We have a safety meeting that the hospital has every morning that we're invited to, but a lot of times don't go because we're busy doing rounds and whatnot. But I find that it's very helpful because the nurses will kind of complain about the residents at these things. And if we have a representative there, we can give the other side of the story, because like most things, there's usually two sides of the story. Whereas if we're not there, which they kind of count on us not being there because most of the time we're not, then it just kind of becomes a gripe about the residence session. So I think just showing up is, as Woody Allen said, 90% of the game in terms of communication.
I think that's a great point, Dr. Ontai. You and I actually serve on some teams together, and I think being present and being actively listening, even if you don't have much to contribute to a weekly or monthly meeting, just making sure that we're responsible enough to keep abreast of what a team is doing is very powerful.
Other comments on barriers or strategies?
Let me just comment, Chris, if you don't mind, on the EMR record as it relates to communication. Is as you know, one of the ideas was to improve the quality of healthcare. And I was very hesitant to get into EMR because I knew it was going to cut on my time to see patients. But I finally did about 3 years ago. One of the things that has helped me the most, to me, is with medications, because now I don't have to worry about legibility. That was a problem. I have an average physician handwriting, so you can imagine. So that's good. That's good. But I came across that literature. The name of the title went something like this, like, when the EMR goes down, comma, communication goes down. Interesting for a medical journal title or article. So the article was about this surgical residency, or this hospital where there's a surgical residency where the EMR record went down for 2 months. And what they found out that in those 2 months, communication between surgery residents, nurses, and other healthcare professionals actually went up, because now the surgical residents, they didn't go to the doctor's lounge or their room to do the notes. They had to go to the hospital. They had to ask the nurses for questions on the patients. They had to ask for the charts and et cetera. You can just imagine. And all of a sudden, they saw their surgical residents, their nurses interacting more with each other. And they did interview them later about those 2 months experience. And they felt definitely, I mean, automatically there was much more communication. They were more happy with each other than when the EMR was in place. So it's just something to make you think. We always think about EMR improving communication is faster, but not necessarily. I think we still need to have some time face-to-face with our other healthcare professionals. Just wanted to add that because I did not add it earlier. Any comments?
Hello, everyone.
Bridget, we cannot hear you very well.
Okay, I'm fine.
There,
You hear me now?
yes, go ahead.
My name is Bridget. I'm the services coordinator at Pittman Northwest. My challenge with communication for us, those who are not, is our accent. How do we overcome that barrier? Because I try to communicate with the doctors, they don't quite understand me. I don't quite understand what they're saying because we come from different cultures, different backgrounds, different accents. And I try to communicate with other colleagues, and forget me, I try to educate patients, and they might not really understand what I'm saying. So in such circumstances, how do we overcome such a barrier when it comes to accent, for instance? Thank you.
Let me just repeat the question for everybody. What I heard Bridget saying was that for those for whom English is not their first language, perhaps they struggle to be understood or struggle to understand others for whom English is their first language because of an accent. And we know that we work in these wonderfully rich and diverse environments, especially in higher education, where we have people from all over. And so that can certainly be a barrier. Anybody have a comment about ways to overcome that?
I think that's a really challenging barrier that we can all relate to. And one of the things that I think really helps is anytime you're putting a team together to sort of begin with clear guidelines on communication. You know, we talked about keeping things simple and avoiding jargon, and a lot of times that really puts walls up between people who are from different disciplines, cultures, languages. If we use acronyms and jargon that aren't universally understandable, so sort of setting some communication guidelines from the get-go and making sure that they're simple and, you know, very specific to be universally understandable, I think is helpful. And anytime that's a challenge, I always encourage perhaps looking at cultural diversity training, inclusivity in language, and you don't have to reinvent the wheel on that. There are so many great programs out there. They don't even have to be specific to health, but they're out there that provide some training in communicating more effectively, more inclusively across cultural diverse groups. And doing that before you get started, if you're concerned about that, can be really helpful.
I think too, one way to encourage our students to deal with this, because certainly this is something that comes up with students and faculty together. I worked on a diversity initiative where we were encouraging students to let their ears adjust. They are going to be working in a multicultural world, and it is a skill to get your ears accustomed to hearing an accent different than yours. And that doesn't even necessarily mean different countries. I'm from the North. When I moved to Texas, I had to adjust. So I think that, as we work with our students, we need to encourage them to develop that muscle of getting their ears accustomed to hearing accents that are different than theirs.
So I wanted to comment, if I may.
Yes, please.
So I think it is a difficult challenge, and I think the suggestions that were put forward are useful. But in addition to that, I think if we have a clear understanding of the goal, what we want to build together, then people establish trust and they become more forgiving in trying to reach out to the other culture, the other accent. So, and that is a difficult thing to establish, but once you're there, your team can really fly. But that's what you have to work on at the beginning, to say, it is useful to have diversity. So that's my comment.
I think Dr. Castro will talk about trust a little bit as we close the session in about 10 minutes, but I think that's a really great contribution.
Hi, my name is Robert. I'd like to ask a question, if I may.
Yes.
I'm curious if you have done or completed any training in simulation and how to break down some of these communication barriers. And if you could just comment if you did utilize simulation as a modality to train, different professions. And then if you would be willing to kind of talk about that a little bit more offline. Thank you.
I can speak to that briefly. Yes, we one big initiative that we're fortunate to have supported by our leadership is that all of the faculty within the College of Nursing were offered Team Steps Master Training. And if you're not familiar with Team Steps, it's a team communication effectiveness training that's put out by AHRQ. And all of our students take a course in which they are trained in Team Steps communication. And part of that training includes simulation, where they use some of the communication tools in a patient care setting that is simulated and safe. So they can use what we call, the SBAR tool that many of us are familiar with for giving report, the CUS tool, where if you're in a position where you feel like patient safety is compromised, you say, I am concerned, I feel unsafe, this is a safety issue, I am uncomfortable is the other U that you can use. And they get to put those into practice. And I think the hardest part about that, Robert, is coordinating schedules when you're putting together interprofessional simulations across disciplines, because, medicine works on a different semester schedule than nursing, et cetera. And so that's the biggest challenge. Everyone wants to do it. It's just, can we get the schedules together to do it? And with COVID, we have some Zoom simulated situations where we've had to resort to doing it on Zoom, and that's helpful too.
Exactly. So the units, I think, would have been happier.
Other thoughts or questions?
Hi, this is Vani. I have a question. Is there any training for students and faculty on racism and how to be mindful about it, or anti-racism in medicine?
Bonnie, what institution are you at?
I'm in private practice.
Okay.
I'm a clinical assistant professor with College of Medicine at A&M. So.
Okay. So there's actually quite a bit at Texas A&M. We have a number of resources available for students and staff and faculty alike. Texas A&M has a diversity plan and has actually received a number of awards for the diversity initiatives here. If you'd like, you could email me afterwards, and I'd be happy to share that information with you. There's also some efforts specific to the College of Medicine. You have an Associate Dean for Diversity in the College of Medicine, and there are a number of initiatives there. So we would be happy to share that with you.
Thank you. Thank you.
Other thoughts about interprofessional communication, any strategies or barriers or issues that you see in practice or in the educational setting? What we could do now then is move to some of the strategies that Drs. Castro and Pittman have put together to share with you so that you walk away with some tools in hand for interprofessional communication.
Okay, thank you, Chris. The strategy to overcome effective communication, I really think starts within the single person, within a single student, within a single professional. We have to actually take time and look inside of us. What are my biases? Where do I need to change? So first thing is we gotta be open to change. Historically, physicians have been the leaders of multiple teams, but it doesn't have to be that anymore. I mean, with a complexity of care and developments, pharmacists now can lead pharmacy and therapeutics committees in the hospital. Nurses can easily be the leaders in hospice care, end-of-life committees, and other committees. So we gotta be open to that. We gotta educate our students that different professionals will lead different type of teams. For instance, nowadays with the scope of practice, many professions are expanding their scope of practice. Clinical pharmacists are now seeing patients in the clinic, ambulatory care, in collaboration with physicians. Students are being more accepted. Not accept as a member, not as a junior team, a member. They all contribute, we all contribute to the team in our own different ability. This fortifies the team, it strengthens the team. So we need to accept the knowledge and expertise that other professionals bring. We gotta be accepting of that before we even team members. I think this has to take place even before we become part of the team, part perhaps of that job. We gotta be already open, we gotta be accepting, we gotta be trusting. And in a way of trusting, we gotta trust the expertise of other professionals. I know in my case, it took me a while to trust what the nurse practitioner was doing or what the pharmacist working in my office was doing. I always kind of double check it, but no, they were good. Everything was good. We just gotta trust what they bring in. We gotta have confidence and we gotta rely that what they're providing is good, competent care. And this will improve the patient-centered care. So let me stop there. My point was it has to start within us, and then we can apply some of the other strategies to improve communication.
Dr. Pittman.
I almost did the thing where I forgot to unmute. Real quickly, some foundational strategies when you're looking towards building your team and having effective communication. We really need to be very open and honest about any profession-based biases that we have. One issue that we have in nursing is, you know, if especially the more traditional nursing role where we may not feel like we have an equal seat at the table when providers or physicians are involved, because they are the diagnosers, they are the orderers, we carry out the orders and care for the patients. And so, you know, sort of those power-based roles can really create biases when you're working on an interprofessional team. So acknowledging those and exploring those and examining them, along with a lot of what we've talked about, the personal biases that we bring to the field. So some conscious and unconscious bias training can be really helpful. I know the AAMC, the American Association of Medical Colleges, has some great free training that tools that you can use related to this. So that's another resource that we have. And then when we talk about more functional strategies or operational strategies on the next slide. We have great tools like the SBAR tool. If you've never used this, this is really highly integrated into patient care when you're giving report from discipline to discipline or from individual to individual, for example, in nursing shift change. That has some very clear guidelines to make sure that the patient safety is the #1 priority. And so incorporating these tools and other types of training into your existing curriculum where you work is one way to really create a universal language that's being more and more accepted and more proven in the literature to provide safety. Again, we talked about avoiding profession-specific jargon. And if someone says something that you don't understand, like, I'm going to give you an SBAR, and you don't know what that means, say, hey, what is SBAR? I've never heard that before. Can you tell me what that is? And that really encourages us to avoid using that discipline-specific language. So those are some great strategies that you can use both in your foundation when you're building the team, and then as you're teaching a communication from day to day that you can use.